past 6 months, now involving her ankles and lower legs. She has noticed an increased difficulty breathing when lying flat, requiring multiple pillows to sleep comfortably. Additionally, she mentions the recent onset of frothy urine and unexplained weight gain. She denies any recent infections, changes in meds, or exacerbation of chronic complications. Her past medical history is pertinent for hypertension and hyperlipidemia. Her medication she's on is amlodipine and atorvastatin. And now for her exam. Her vitals, BP is 160 over 95. Heart rate is Welcome back to the Ninja Nerd Podcast. Today we're talking about glomerular diseases. That includes nephrotic syndrome and nephritic syndrome.
Yeah, it's a good one. I think also another thing is nephritic syndrome. Sometimes we also refer to that as glomerulonephritis too. So we'll kind of have a little bit of discussion about that.
All right, cool. So we have two cases, one on nephrotic, one on nephritic. Let's go ahead and start with case one and get right into it.
Let's do it, bud.
All right. So we have a 65-year-old woman presents with persistent leg swelling and difficulty breathing at night. History of her HPI. The patient reports experiencing significant and progressive leg swelling over the past 6 months, now involving her ankles and lower legs. She has noticed an increased difficulty breathing when lying flat, requiring multiple pillows to sleep comfortably. Additionally, she mentions the recent onset of frothy urine and unexplained weight gain. She denies any recent infections, changes in meds, or exacerbation of chronic complications. Her past medical history is pertinent for hypertension and hyperlipidemia. Her medication she's on is amlodipine and atorvastatin. And now for her exam. Her vitals, BP is 160 over 95. Heart rate is 88. Respiration is 18 per minute. Temp is 98.2 Fahrenheit. And her O2 sat is 95% on room air. For general, she is an obese female, appears tired. Cardio, regular rate and rhythm, an S4 gallop, no murmurs. However, she does have a 3+ pitting edema in both lower extremities. For respiratory, is clear to auscultation bilaterally, no wheezes, no crackles. Abdominal is soft, non-tender, no bruits. Neurologic, alert and oriented, no focal deficits. And her skin is dry, it's excoriated, it's scratch marks, but no rashes. We do go ahead and order some labs for her. So we get some laboratory findings back, and it's the following. Creatinine is 2.0. Previously, it was 1.2 6 months ago. Her BUN is 40. Hemoglobin is 11. Potassium is 4.5. Sodium is 135. Phosphates 3.5. Calcium is 9.2. Albumin is 2.8. Her urine protein creatinine ratio, or UPCR, is greater than 3.5. GFR is 35, and her lipid profile is pertinent for elevated LDL and triglycerides. We do get some imaging. We have a renal ultrasound showing normal-sized kidneys with increased echogenicity, suggestive of a chronic disease. There is no hydronephrosis or stones present. For her echocardiogram, we also get that. And the echocardiogram reveals a left ventricular hypertrophy with a preserved ejection fraction. So, Zach, I know that was a lot of information.
Yeah.
But based upon all this information, I want to go over just a couple of questions to start us off with case one.
Let's do it.
So, does this patient have nephrotic or nephritic syndrome, and why?
Yeah, that's always the first thing to ask about when you're talking about glomerular disease. So the first thing I would look at is oftentimes the degree of proteinuria. The degree of proteinuria is really the biggest thing to look for. And what we like to see is something that's greater than 3.5 grams within a 24-hour period if you get a 24-hour urine collection. And the reason why is in nephrotic syndrome, there's podocyte injury and there's loss of the negative charge in the GBM. And so these patients lose heavy amounts of proteins. So if I see greater than 3.5 grams per gram, which is their spot ratio, so we just take a urinalysis at one point, that tells me that they're making a lot of protein over a 24-hour period. Oftentimes we try to say that this is usually a 1-to-1. So for example, if I see the ratio is greater than 3.5, let's say it's 3.5, that oftentimes, not perfectly, will say that it's likely that they're making at least 3.5 grams within a 24-hour period. So this is definitely nephrotic range proteinuria. The next thing is like nephrotic syndrome. It's not just proteinuria. You have to have other features. And so what I have to have here is I have to have basically proteinuria has to be greater than 3.5 grams in a 24-hour period, or a spot that's greater than 3.5 for the ratio. Second is I have to have low albumin in the bloodstream. So hypoalbuminemia. And in this case, it's 2.8. So it is low. All right. The next thing I need to have is edema. And this patient does have what we would say is edema, particularly in the lower extremities. So 3+ pitting edema. A big thing to remember here is oftentimes this is one of the common presentations for patients who have nephrotic syndrome is they come in with a lot of swelling and edema and weight gain. And the first thing that you want to have to think about is, well, there is other diseases that cause edema. Oftentimes the most common one is heart failure. And so what I would like to do is know what their heart function is. And when I look here at the echocardiogram, they have a preserved ejection fraction. They have some left ventricular hypertrophy, but no diastolic dysfunction. So it kind of like makes me think it's not really heart failure that's driving their edema. Cirrhosis would also be another one that can cause this because it can cause low albumin, but there's no underlying history of underlying cirrhosis in this patient. So I would think that that's less likely. And also cirrhosis doesn't cause this degree of heavy proteinuria. So the edema is likely a result of nephrotic syndrome. And the last thing that you oftentimes need to truly make the diagnosis is hyperlipidemia. So elevated LDL and triglycerides tells me that this patient has proteinuria, at least nephrotic range, greater than 3.5 in a 24-hour period. They have low albumin, so hypoalbuminemia in the bloodstream. They have edema, which in this case, there's no other alternative cause of it, like CHF and cirrhosis. And then on top of that, they have hyperlipidemia. And that is oftentimes what we look for as the criteria to make the diagnosis of nephrotic syndrome. Now, with this being said, it's not always perfect, but when we talk about edema and nephrotic syndrome versus in other areas tend to be more within the facial area or periorbital area as compared to the more dependent areas and cirrhosis and CHF, but that's not always perfect. So again, I would say that this patient fits nephrotic syndrome as their glomerular disorder.
All right. So what complications should we be concerned for? What are we looking out for here for complications? Anything that's really kind of alarming?
So the biggest thing with nephrotic syndrome is whenever they have low albumin, you can't hold fluid into the circulation as well. So the oncotic pressure drops, fluid leaks into the interstitial spaces, and they can develop edema. Plus they have less the underfilling hypothesis. So they don't have as much fluid within the circulation. So it activates the renin-angiotensin-aldosterone system and they retain sodium and water. And so they could present with like pulmonary edema and pleural effusions. This patient does have like what kind of sounds like orthopnea or paroxysmal nocturnal dyspnea. I didn't get a chest x-ray to look to see if they have any, but I imagine that they probably have some degree of pulmonary edema or pleural effusion. That's a pretty common area. They can also it can actually develop ascites. I don't see anything here that mentions that the patient has any evidence of ascites, but pedal edema, which is usually pitting, is a very common one as well. Hyperlipidemia, we already talked about that one, is a big one. The other thing that I actually get really nervous about is when you dump a lot of protein into the urine, your liver compensates by kind of trying to be able to increase the production of lipoproteins. And that's where we see that elevated LDL and triglycerides. Depending upon the level of that could increase the risk of atherosclerotic cardiovascular disease. So I have to be on the lookout for that. But I'd say the other really big thing here, it's not mentioned, but I'd be very careful. As you dump more and more protein into the urine, it's not just albumin. You can dump immunoglobulins, and these are important for fighting off infections. And so these patients are usually higher risk for infections, especially from Streptococcus pneumonia. And the last thing I would also be really, really, really careful of here is when you dump proteins, you also dump things like antithrombin 3, protein C, and protein S, which are really important anticoagulants. And if you lose those anticoagulants, you're more prone to clotting. So other things that I would be on the lookout for if I think that a patient has nephrotic syndrome is hypercoagulable states. I'd be watching out for high risk for infections, and I'd be watching out for a lot of hyperlipidemia related complications like atherosclerotic cardiovascular disease. So that's what I would be thinking about, but I think their biggest manifestation is tending to be the edema factor.
Okay. So now, what is the likely cause of this patient's nephrotic syndrome? How do you determine that?
That's so difficult. It's like, because that's why oftentimes on the exam, it's just get a biopsy and see if there's any kind of like an underlying primary glomerular disorder that's present there. I'd say it's always good to rule out kind of like systemic illnesses that cause secondary glomerular involvement. So for this, I always want to rule out diabetes. Does the patient have a history of diabetes? Get an A1C, check on that. And do they have any other, other manifestations of diabetes like retinopathy or neuropathy or things like that. So that's one thing I would do is I would check an A1C.
Okay.
I'd also want to rule out amyloidosis. That's a rare one, but I would consider potentially for these patients maybe getting like an SPEP and a UPEP to make sure I rule out any kind of underlying, like a lot of proteins that are being deposited. And depending upon the findings of that, you could do a fat pad biopsy. And I think the last thing I would want to do is also rule out what's called a primary membranous nephropathy. And we can do that with an anti-PLA2 receptor. So that's kind of the way that I would start off. And then based upon that, I would kind of start ordering other tests. But oftentimes they say to obtain a lot of different tests. They'll tell you to get like an ANA, an anti-double-stranded DNA to rule out like lupus. You could also check infectious etiologies like hepatitis B, C, HIV, syphilis. But those would be the ways that I would kind of start off. But most likely, I'm going to end up needing a renal biopsy to really help me to determine what's the likely cause, especially if there's no diabetes, there's no amyloidosis, and there's no anti-PLA2R. It could be really anything else, and I need to probably get a renal biopsy to nail that down.
It's funny because we already got a pretty good amount of lab work done for this patient.
All right.
So it's kind of interesting to see how much more lab work we can order for them.
Yeah, exactly.
So it's like almost like you start off with, a general idea, and now you're like really honing in.
Yeah, that's the whole concept is you get the patient who you think has nephrotic syndrome, and then you say, okay, I think it's nephrotic syndrome rather than nephritic syndrome. How do I figure out the cause?
Yeah.
And then in order to do that, really the best answer would be a biopsy, but check other things, at least an A1C, an SPEP, UPEP, and then check an anti-PLA2R. But you can add on other tests if you have a degree of suspicion for an underlying kind of glomerular disorder that has a secondary cause. And that would be like hepatitis, HIV, syphilis, et cetera.
All right, so let's go ahead and do the labs that you had just requested, labs and biopsy, and let's see what we come up with.
All right.
So we do get the serum protein electrophoresis, the SPEP, and that shows hypoalbuminemia with nonspecific gammopathy.
Okay.
We get the urine protein electrophoresis, the UPEP, that's significant albuminuria. We have a hemoglobin A1C of 5.9%, so we can rule out diabetes.
Okay.
We have the ANA, the anti-nuclear antibody, negative. The anti-dsDNA, negative. We do the infectious etiology, so we check for hepatitis B, hepatitis C, HIV, syphilis. They're all negative.
Okay.
And then we do finally the one that you requested was the anti-PLA2R antibodies, which comes back positive.
Okay.
Finally, we do the biopsy that you had requested, the kidney biopsy. Upon histopathology, we see subepithelial deposits and spike formation consistent with membranous nephropathy on EM. It has a granular appearance on IF.
All right.
So, Zach, a few more questions about these findings that we just kind of talked about.
Yeah.
Given the patient's labs, biopsy findings, what can you say now is the likely cause of their nephrotic syndrome?
Yeah, and so that kind of, whenever you have nephrotic syndrome, the differential is kind of somewhat wide. You have something called minimal change disease. You have focal segmental glomerulosclerosis, and you have membranous nephropathy. And oftentimes we define these as these are primary glomerular disorders, meaning that they really only affect the glomerulus. And then you have other ones which are systemic illnesses that cause secondary glomerular involvement, and that's diabetes and amyloidosis. So with the diabetes, that's off the table via the A1C. There's no history of diabetes, and usually they'll have things like retinopathy. SPEP, UPEP does not show any significance of lots of amyloid proteins, especially kind of like what's called AL amyloidosis, which is lots of multiple myeloma. So usually that would have lots of Benz-Jones proteins that would come up here present. So this is not significant. The ANA, anti-double-stranded DNA, these come back negative. This can actually cause membranous nephropathy. It's called secondary membranous nephropathy. Hepatitis B, C, HIV, well, particularly hepatitis B and C, they can cause secondary membranous nephropathy, and so can syphilis. HIV can cause what's called focal segmental glomerulosclerosis. But the big giveaway here is the anti-PLA2R. If that's positive, I want to say, if I remember correctly, the sensitivity and specificity of this is like, it's somewhere around 95%.
Oh, wow. Okay.
So it's pretty good, and you could honestly forego a biopsy if this comes back positive. However, I think a lot of clinicians are still in the area where they want to, err on the side of caution and get that biopsy, because if this is the case, you're putting these patients likely on immunosuppressants for a long, long time.
Okay.
And so you want to make sure that you nail down that diagnosis. But right away, when I see that positive, that's primary membranous nephropathy. I technically don't need a biopsy, but some will say, just get the biopsy. When you get the biopsy, it shows this kind of what we call immune complex deposition, which is via the granular appearance on immunofluorescence or IF. And then these subepithelial deposits with a thickening of the GBM, that's really consistent with membranous nephropathy. So it's minimal change disease. Usually that would have what's called podocyte effacement in a normal glomerulus. Focal segmental glomerulosclerosis would have sclerosis and cyanosis of the glomeruli with podocyte effacement. And then diabetes, usually that causes what's called Kimmel-Steele-Wilson nodules. And amyloidosis, you put a special stain. It's called a Congo red stain, and it turns like an apple green color. So all of these are not consistent with what I see here for membranous nephropathy. And then we've ruled out other potential things like amyloidosis off of the SPEP and UPEP, diabetes off the A1C. We've ruled out other secondary causes of membranous nephropathy like lupus, hepatitis B, C, and syphilis. And then we ruled out the secondary cause of focal segmental with the HIV being negative. And then we even confirmed even a double confirmation with membranous with the anti-PLA2R. So this is likely membranous nephropathy as the cause of nephrotic syndrome.
All right, so we have the underlying cause. We've determined that. Now I want to kind of talk more in like a stepwise approach of how do we manage the complications that we're going to be seeing here.
Yeah, let's do it.
So I want to start with edema and work our way down.
All right, let's do it.
All right, so edema, what do we do?
For this one, oftentimes you treat the underlying cause and hopefully, for example, for this patient, we'll talk about it later, you'll put them on immunosuppressants. And that actually will help to kind of suppress a lot of the damage to the podocytes and a lot of the changes to the GBM. And so you will lose less protein and that will improve because as you're losing albumin, you're potentially losing this factor that's kind of keeping water and other plasma inside of the bloodstream. So that will help. But the biggest thing is oftentimes just restricting sodium to some degree, because if you cause them to have a lot of sodium, that can also cause them to retain a lot of fluid. So I'd say a degree of salt restriction to a degree. But oftentimes these patients, you got to give them diuretics, like loop diuretics. And I've noticed these patients, you have to give them like heavy doses. I would consider this diuretic resistant kind of a disease. And this is oftentimes what happens is you get patients who come in, they have heart failure, or you think that they have heart failure. They have pulmonary edema, they have a peripheral edema, and you give them just tons and tons and tons of furosemide. And you're just like, man, I can't get this fluid off. Oftentimes that's when you start thinking about nephrotic syndrome. So this is one where I would give them sodium restriction and I would start hitting them with pretty heavy doses, like 2 to 3 times your normal dose of furosemide for these patients. All right. So that's how I would do that one.
Cool. Next one is hypertension and proteinuria. How would you manage that?
So hypertension is more common in nephritic syndrome, but it can happen in nephrotic syndrome because of the renin-angiotensin-aldosterone system activation. So the best thing to do is suppress the renin-angiotensin-aldosterone system. And so ACE inhibitors, ARBs, are really, really good at this because you're basically blocking angiotensin 2, which is the one that can cause this higher blood pressure and sodium and water retention. Proteinuria, funny enough, ACE inhibitors and ARBs as well. And so what's great about these drugs is what they do is they block angiotensin 2. Angiotensin 2 has an effect in being able to cause vasoconstriction and increase ADH and aldosterone production. So if I block that, that'll bring my blood pressure down. The second thing that it also does is it causes the efferent arterioles to vasoconstrict. And so if I block that, they'll dilate, and that kind of reduces the pressure inside of the glomerulus, and it makes it easier for blood to leave the glomerulus. And so the pressure isn't so high that it's filtering out lots of proteins. And so that's one thing I would also see is that this can help to reduce proteinuria. So edema, I give the furosemide, and then hypertension and proteinuria, I give ACE inhibitors and ARBs.
Okay.
Or ARBs, sorry.
Yeah. How about the hypercoagulable state?
This one's a tough one. So these patients are high risk for DVTs, PEs, and if they have a DVT or PE, I'm starting them on anticoagulation, especially if they have nephrotic syndrome. But let's say that they've never had a provoked VTE, so they've never had a DVT, PE, or anything like that. Then it's more about kind of stratifying the patient and determining their risk. Because if you start somebody on an anticoagulant, you put them at risk of bleeding, but you also want to do the purpose of it, which is prevent them from developing clots. So if a patient has risk, so what the guidelines I think say according to KDIGO is that if a patient has risk factors, malignancy, taking oral contraceptives, obesity, prolonged immobilization, etc., and they have a very, very low albumin, let's say less than 2.5, that really brings about the risk that these patients are super high risk for complications like a DVT, PE, and the biggest one, which funny enough, you see it with membranous nephropathy, is renal vein thrombosis. So in that scenario, I'd start them on anticoagulant. You can do warfarin, you can do heparin. There is newer research that's saying that suggesting that DOACs can even be helpful as well. But from what I've seen, usually warfarin is kind of the preferred one in this particular scenario.
How about the higher risk of infections?
So this one's more just preventative, right? So in the sense that like you're not going to particularly treat them with prophylactic antibiotics. They are high risk for pneumonia. They are high risk for spontaneous bacterial peritonitis, but really you're just trying to reduce the risk of them developing infections, especially pneumonia. And one of the things is that pulmonary edema can create kind of a nidus for bacteria like strep pneumonia to grow. And so you actually want to just make sure that they get their pneumococcal vaccination and influenza vaccination just to prevent the risk of them developing infections. But I'd say the heaviest one is that pneumococcal vaccination. That's a really important one.
How about hyperlipidemia? Is it just lifestyle changes or are we medicating?
You can do lifestyle changes. Oftentimes treating hyperlipidemia in these patients is the same kind of guidelines that we would employ for any other person who has high cholesterol or high LDL. We say LDL greater than 190, you get started on a statin. If it's, particularly a patient who's 40 to 75 years of age and their risk is relatively high for atherosclerosis, then we'd start them, especially greater than 7.5%, we start them on a statin. If they have diabetes and they're 40 to 75, we start them on a statin regardless of what their risk is. And then if they have any clinical atherosclerotic cardiovascular disease, they had an MI, they have PAD, they have a TIA or a CVA, then you get started on a statin.
Got it. All right. And the last one is really just the treatment of the underlying cause.
Yeah. So if this is membranous nephropathy, that's really the key thing here is that a lot of the times everybody thinks, oh, it's just immunosuppressants. That is true if it's primary. So if you've ruled out secondary causes, for example, minimal change disease is one of those that they say, oh, you start steroids, edema just melts away and they get better. That's true if it's primary, but you have to rule out the secondary causes. Same thing with focal segmental. If it's primary, you put them on steroids and immunosuppressants, they'll get better. But if it's secondary, you're not going to help them. And so you have to figure out the underlying cause. If it is primary, putting them on a good dose of corticosteroids, adding on an immunosuppressant for a long-term control, I'd say the best one, the most kind of like tried and true one is cyclophosphamide. You can also consider things like mycophenolate, Mofetil, and then even tacrolimus is another one as well. But oftentimes, more than not, putting them on a steroid and cyclophosphamide for membranous nephropathy is going to be the go-to. Focal segmental, kind of same thing. You can put them on a steroid, see how they do. If they don't respond well to the steroid, you can either use a steroid plus tacrolimus is also preferred. Minimal change, you just put them on a steroid. Diabetic nephropathy, you treat the underlying cause, improve their diabetes, strict glucose control. Amyloidosis, you treat their underlying disease of amyloidosis. It's just really important. If they have, like, for example, let's say they have membranous nephropathy and their hepatitis B was positive, you don't put these patients on steroids. You treat the hepatitis B.
Yeah.
If they have HIV and they have FSGS, you treat the HIV. So it's important to know that it's not always immunosuppressants. It's treating the underlying cause. If it's primary, it's immunosuppressant. If it's secondary, then you treat those underlying diseases.
You got to dig a little deeper.
Exactly.
All right. Well, let's move on to case 2.
Let's do it.
All right. So we have a 65-year-old woman presents to the clinic with fatigue, swelling in her legs, and difficulty breathing at night. The patient has noted significant and progressive swelling in her legs extending to the ankles and lower legs over the past 3 months. Recently, she has required multiple pillows to sleep due to difficulty breathing when lying flat. She also reports a marked decrease in urine output and describes her urine as increasingly dark and frothy. Yuck. The symptoms have rapidly intensified over the last few weeks. Past medical history, she has type 2 diabetes, hypertension, hyperlipidemia. Medication she's on is metformin, lisinopril, amlodipine, atorvastatin, and an insulin. Okay, exam. So her vitals, BP is 170 over 95. Yeah, her meds ain't working.
Yeah, you're starting to wonder, right?
Heart rate is 88. Respiratory rate is 18. Temp is 98.2. And her O2 sat is 92% on room air. General, she's an obese female, appears exhausted. Cardio, she has a regular rate and rhythm. S4 gallop, but no murmurs. Respiratory, clear to auscultation bilaterally, no wheezes or crackles. Abdominal is soft, non-tender, no bruits. Her neuro exam is alert and oriented, no focal deficits. And her skin, like before, the other patient is dry, excoriated skin, scratch marks present, but no rashes. We get some lab findings. We have a creatinine of 4.5. This is up from 2.0 2 months ago. BUN is 80. Potassium is 5.6. Sodium is 132. Phosphate is 4.8. Calcium is 8.4. We get a UPCR again like before, and we get 2.5 this time.
Okay.
Albumin is 2.9, and her GFR is a shocking 15. That's in the shadow right there.
Yeah, she's fucked.
She's We also get a urinalysis with microscopy. The following results appear. Color is dark brown. Appearance is cloudy. Protein 3+. Blood 2+. Red blood cells, we have 20 to 30 per high power field. White blood cells, 5 to 10 per high power field. And we get red blood cell casts that are present. We also do some imaging studies. Like our first patient, we get a renal ultrasound and an echo. In this patient, the renal ultrasound is showing bilaterally small kidneys with increased echogenicity and loss of the corticomedullary differentiation. Echo, just like before, we have a left ventricular hypertrophy and a normal EF. So Zach, based on the above information, I would like to go in that stepwise approach again.
Yeah.
This one's going to be pretty obvious.
Yeah.
Does this patient have nephrotic or nephritic syndrome? But more importantly, why?
Yeah. And so this is nephritic syndrome. And there's a couple of reasons why. So first thing I always say is look at the urine protein creatinine ratio. If you have a 24-hour urine protein, one of the two, and look to see if it's nephrotic range or not. That you got to be careful. There is two disorders that can have nephrotic range proteinuria and still be nephritic syndrome. And that's why people sometimes hate this disease. And that is lupus nephritis type 4. And then the other one would be membranoproliferative glomerulonephritis. And so that is possible to still have it, but there's other things that we look at anyway. But for the most part, it's usually subnephrotic range. And so it's less than 3.5. In this case, it's 2.5. So it's sub. So I'm going to go with that being kind of more likely to lend to me nephritic syndrome, but that's not all I need. The other thing I like to see is any evidence of edema. And so the patient does have some edema based upon how they were talking about in their HPI.
Yep.
And it's usually not going to be as bad as nephrotic syndrome. So it's usually going to be a little bit less intense. But the real big thing here is the blood pressure. Hypertension is a really common one.
Right.
And so usually these patients have pretty high blood pressures that are usually kind of like sometimes refractory to maybe a couple different antihypertensives.
I was going to say, even though they're being controlled, it's not doing anything.
Yeah. So they're on lisinopril and amlodipine, still high
Nothing.
BP, right? So that's pretty common. And that's one really big feature. So if a patient has subnephrotic range proteinuria, maybe some edema, but not to the level of nephrotic syndrome, but they have really bad high blood pressure. So hypertension, that's starting to make me think about nephritic syndrome. The other thing here that's really making me think about it is the really bad kidney injury. So oftentimes we look for a very concerning finding with nephritic syndrome, which is called RPGN. It's called rapidly progressive glomerulonephritis. And that's usually whenever their renal function like significantly increases within like days to weeks, sometimes months. And it's very, very quick. And so that's very concerning. And I see that the creatinine went from 2 to 4.5, BUN's up to 80. They even have a little bit of a derangement in the potassium slightly. So, and their GFR is down. I'm kind of nervous that they have a kidney injury. And so if I start seeing things like oliguria, azotemia via the elevated BUN creatinine, I'm starting to be potentially concerned about RPGN or acute kidney injury. So hypertension, acute kidney injury, potentially RPGN, and then on top of that, subnephrotic range proteinuria and the edema, that's my initial thoughts. Yeah. What I really go to is the urinalysis, and that's going to be my bread and butter here that's going to tell me about it. I see here that they have a lot of blood in the urine, so there is hematuria, but I look at the red blood cells, they got 20 to 30, so that's a pretty good amount.
Yeah.
So if they're having that much red blood cells in the urine, they have hematuria.
Red blood cell casts.
Yeah, that's the giveaway. So
Okay.
if I look at their actual casts and I see red blood cell casts, or I see dysmorphic red blood cells, that's usually the giveaway that this is likely kind of a nephritic syndrome or glomerulonephritis. So biggest things here is the subnephrotic range proteinuria, the hematuria with red blood cell casts, the hypertension, and the acute kidney injury suggestive of RPGN. That's the things that are making me think that this is definitely nephritic syndrome as compared to the nephrotic syndrome.
So let's move into then how you determine what the cause of this nephritic syndrome is. Kind of some specialized lab testing, maybe a biopsy. What do you do in that situation?
Yeah, so right away, I think this is definitely like nephritic syndrome. So my differential at this point is I kind of think about it in groups. So I think about, usually what's called the first one, we're going to call it type 1. We'll say this is a linear type. So this is usually antibody mediated. And the primary antibody is called anti-GBM antibodies. And so if these are positive, it makes me think about anti-GBM disease or good pasture syndrome. The only way I differentiate the two is good pasture involves the lungs and anti-GBM does not. The second one is posse-immune, and this is usually ANCA vasculitis. So these are antibodies that are generated against usually neutrophils, and this can also cause a pretty nasty injury. And so ANCAs, if they're positive, if it's C-ANCA positive, it makes me think about GPA, which is granulomatosis with polyangiitis. And if it comes back positive or P-ANCAs, then I'm thinking about potentially EGPA, which is your Churg-Strauss or eosinophilic granulomatosis with polyangiitis, or MPA, microscopic polyangiitis. And so that's kind of what I would think about for that one. If those don't come back or yield anything, then I would start thinking a little bit more about immune complex deposition. And so I go through post-streptococcal glomerulonephritis. So I look for a history of recent strep infection, but I'll order titers that suggest a potential exposure to strep, such as an anti-ASLO and an anti-DNase B antibody. Second thing is I'll rule out lupus nephritis type 4. So I'll check an ANA and an anti-double-stranded DNA because that can also cause this. And then the other thing is membranoproliferative glomerulonephritis. This one can actually very commonly be due to hepatitis, especially hepatitis C and B. So I'll check those and I'll check a C3 level. And the reason why is post-streptococcal glomerulonephritis, MPGN, and lupus nephritis cause massive consumption of C3 complement proteins. And so those would be pretty low if one of those were positive. And then I could check a nephritic factor. That could be this super rare little a little SOB that binds the C3 convertase and causes dense deposit disease. Super rare, but if I wanted to, I could check that one and make sure that that one's potentially not positive.
At this point, you might as well just throw it in there.
Yeah.
Let's just throw it in and be thorough.
Yeah. And then I get the biopsy, and the biopsy is going to be the best thing for me because it'll tell me right away, most likely what's the cause. And I would look at it under light microscopy to see if there's glomerular crescents, because that's what I'd be super concerned for. I'd look at the immunofluorescence to see the pattern. So if it's granular, linear, or if it's posse-immune. And then lastly, I'd look at the kind of the electron microscopy to give me a little bit better idea if there's any deposition or immune complex deposition. So that's the way that I would kind of do all of these things in kind of in tandem.
Cool. All right. Well, we go ahead and get those labs.
Okay.
And we get the following back. The ANA is negative. The anti-double-stranded DNA is negative. We do an HBV, HCV, HIV, syphilis, all negative. The P-ANCA, C-ANCA are both negative. The anti-ASLO or the anti-streptolysin O, negative. The anti-DNase B is negative. C3 and C4 levels are normal. We do get the anti-GBM antibodies, which comes back positive.
All right.
You think you have your answer there?
Yeah, probably.
All right. And then we throw in that nephritic factor, that comes back negative. For the really important one here, kidney biopsy findings, we do the light microscopy. It shows glomerular crescents found in several glomeruli. The immunofluorescence, linear appearance of IgG along the glomerular basement membrane. So I think we have a pretty good idea of what's going on here, Zach.
Yeah.
Now that we have this great lab workup, we have everything we need. What do we now have to? What tests are the most important in identifying nephritic syndrome?
Yeah, I think we hit a lot of these, but I think the big thing here is our serology kind of yielded us the best result, which is those anti-GBM antibodies that they came back positive. And so that definitely kind of gives me the idea that this is either anti-GBM disease or Goodpasture syndrome. It would take a little bit of clinical correlation to look and see if they have any alveolar hemorrhage or any hemoptysis or anything like that. Nothing's really mentioned in the history that I remember. And then there's no kind of chest x-ray to really suggest if they're having like infiltrates in their chest and stuff. So I would kind of be going out a little bit on a limb and say it's anti-GBM disease. Either way, it doesn't matter. Yeah. You're going to kind of treat them both the same in that concept.
But that does seem the most likely of course.
It seems more likely to be anti-GBM. And so that's what I would go with. And I'd say that the labs kind of tell me that since the ANA, anti-double-stranded, came back negative, no lupus nephritis. All of the infectious panel came back negative. It kind of lends to less likely a membranoproliferative. ANCAs came back negative, unlikely ANCA vasculitis. The anti-ASLO and DNase B, negative, unlikely post-streptococcal, and then there's no history of strep infection within the past 2-3 weeks. C3, C4 normal, no immune complex likely that's occurring here with, PSGN, as well as membranoproliferative, as well as lupus nephritis. And then the nephritic factor is negative. There's no type 2 MPGN. The light microscopy is actually kind of helpful.
Yeah.
It tells me they have glomerular crescents. That means that this patient probably has rapidly progressive glomerulonephritis. And that's usually, most often, patients who present with RPGN, it's almost always due to anti-GBM disease or Goodpasture, or ankylosing. They most commonly present with RPGN. And so that tells me that they're probably experiencing RPGN. The immunofluorescence, if it's linear, it's always anti-GBM or good pasture. If it's granular, it's immune complex. And if there's nothing, like you don't see anything, that's ankylosing. And so that right there, it kind of just is a perfect setup for that this is likely anti-GBM disease.
All right. So like we did with case 1, let's talk about managing some complications. The first 3 here are very similar to case 1. And I'm just curious if there's anything different in talking about edema, hypertension, proteinuria.
No, it's really the same thing. You edema, you kind of restrict sodium, loop diuretics, pretty heavy doses, hypertension, proteinuria, ACE inhibitors, ARBs. That's really the biggest thing.
Cool. All right. So that stays the same, easy to remember.
Yeah, I know. Thank goodness.
The next one is, though, talking about this AKI the patient is experiencing. How do we manage that?
Yeah. So acute kidney injury is a pretty big one. Obviously, it's a lot of this time this is an intrarenal AKI. And so you have to treat the underlying disease. And so that's one thing that I would have to get on top of. But also I have to be very, very vigilant and keep an eye on them developing complications, because you can treat the underlying disease, but that's not going to stop the AKI from continuing to potentially cause complications to arise. So in other words, if I started this patient on all the immunosuppressants and plasmapheresis and their AKI continued to get worse, I have to have a backup plan.
Yeah.
And usually that's indications for dialysis. So I would do my best to manage these patients medically first. If they have an acidosis, give them bicarb. If they have hypervolemia, try and give them heavy doses of loop diuretics. If they have hyperkalemia and hypervolemia, volume overload, I give them loop diuretics. But if they start developing signs of like uremia, they're refractory to my medical therapy, then I'm going to start saying, okay, we should probably start dialyzing this patient. So that's really the best thing, is to, again, you have to treat the underlying cause because you don't want them to continue to progress. But if they develop complications of the AKI, that treatment of the underlying cause isn't going to stop that. It's going to prevent the progression. I got to be ready to treat the complications of the AKI.
So you have your backup plan.
Exactly.
All right. Well, that's a wonderful summary right there of a nephrotic versus nephritic syndrome. I think that really handles this perfectly. I feel like I know them much better now.
Yeah.
It was a pretty cool discussion.
Thanks, man. Yeah. Oftentimes nephritic syndrome is a tough one. There's always so many things behind this one. And again, I think at the end of the day, same concept, nephrotic syndrome is a lot of this stuff. You can hit it with immunosuppressants. You just have to make sure you're treating the underlying cause. So like we talked about anti-GBM disease or good pasture, ankylosing, those are pretty much always like steroids, cyclophosphamide, maybe some plasmapheresis. All the other ones though, except for IgA nephropathy, PSGN, those ones you don't even do anything. You just let them go. They usually get better.
Okay.
And so for those ones, I wouldn't worry too much. But for this one, this patient's going to need a lot of therapy. And I think that they'll turn the corner.
All right. Well, that really concludes this episode on glomerular diseases, including nephrotic versus nephritic syndrome.
Yeah.
I thought it was really awesome. It was a great episode. Thanks,
man. Thank you.
Yeah.
All right. Well, Ninja Nerds, thank you guys so much for listening to this podcast. And I really hope that you guys enjoyed it. I hope that you guys, also enjoy watching the video if you guys are watching it. If you guys have a second, go check out our website. On our website, we have a lot more things that we can offer. So things like notes, illustrations, videos. If you want to learn a lot more, we'll have that available to you guys. But Ninja Nerds, we love you. We thank you. And as always, until next time.
When we talk about excretion of a drug, we're talking about getting rid of the drug. So it's excreting the
Glomerular diseases. That includes nephrotic syndrome and Welcome back to the Ninja Nerd Podcast. Today we're talking about chronic kidney disease, or also known as CKD. It's going to be a fun one. We've got a lot of good stuff for you today.
Yeah, I think CKD is, a lot of this disease is something that you're more focusing on monitoring. Complications can arise throughout the progression of this disease. And I think that's really where the brunt of this cast is going to be focusing on, is what kind of things should we be watching for in patients as their renal function starts to decline, what's going to happen, particularly what are the complications that can arise, and if they do, how do we really get to the bottom of it and treat it? You know what I mean?
Yeah. All right. Before you get into this podcast, please check out our website, ninjanerd.org. Go ahead and subscribe, become a member. We have notes, illustrations. We're having questions. We're going to be prepping for some courses. And then, of course, we have podcasts for you. So without further ado, let's get right into case 1. So we have a pretty long case here, but it's kind of cool how we tie everything together.
Yeah.
So case 1, we have a 65-year-old female presents to the clinic with fatigue, swelling in her legs, and difficulty breathing at night. The patient reports feeling fatigued over the past 6 months. She also notes swelling in her legs that has progressively worsened and now involves her ankles and lower legs. Over the last month, she has had difficulty breathing when lying flat, requiring multiple pillows to sleep comfortably. She denies any chest pain, palpitations, or recent weight changes. She also mentions decreased urine output and a darker urine color. Past medical history, type 2 diabetes, which was diagnosed 15 years ago. Hypertension, diagnosed 10 years ago. Hyperlipidemia, and diabetic retinopathy. Diabetic retinopathy, remember that one? That might be important.
Yeah.
Type 2 diabetes, probably important.
Yeah. Hypertension, probably important.
I guess they all are.
Yeah.
Medications, metformin, lisinopril, amlodipine, atorvastatin, and then insulin. Social history, non-smoker, occasional alcohol use, no illicit drug use. Family history, father has type 2 diabetes and hypertension. Mother had coronary artery disease. For our exam, her vitals were BP is 160 over 95, heart rate 88, respirations 18, temp is 98.2, and O2 sat is 95% on room air. For her general exam, she's an obese female, appears tired. Cardio, regular rate and rhythm, S4 gallop, no murmurs. We do notice a 2+ pitting edema in both lower extremities. Respiratory, clear to auscultation bilaterally, no wheezes, no crackles. Abdominal, soft, non-tender, no organomegaly, no bruits. Neurologic, alert and oriented, no focal deficits, and skin is dry, excoriated skin with scratch marks, no rashes. Okay, so let's get into some lab findings here. We order a whole bunch of tests and we get these findings back. Creatinine, 3.5. Previously, it was 2.5 6 months ago. BUN is 60. Hemoglobin is 9.8. Potassium is 5.9. Sodium is 133. Phosphate is 5.5. Calcium is 8.2. The UACR is 320. Parathyroid hormone is elevated. Albumin is 3.2. Her GFR is 20. Hemoglobin A1C, 8.1%. Lipid profile, elevated LDL and triglycerides. And so recipe for disaster there.
Yeah. Yep.
We get some imaging findings. We do a couple different things here. We do a renal ultrasound. We find that bilaterally she has small kidneys with increased echogenicity and loss of cardiomedullary differentiation. For her echocardiogram we note left ventricular hypertrophy, but a normal ejection fraction. So Zach, based on the above information, I have a couple of questions. Let me start with question 1, and where do we go from here?
Okay.
What stage of CKD does this patient have, and how is it determined?
Yeah, so definitely CKD based upon a couple different ways that you kind of diagnose CKD is based upon the GFR. That's oftentimes the most common way. And so we look at the GFR, and usually if it's like anywhere, greater than 90, we say it's kind of normal. But if it's like less than 90, then we start to get a little bit more questions, particularly, right? So for example, there's CKD like 1, and that's usually when it's, around 90, and then we get into CKD 2. That's usually where it's between like 60 to 89. CKD 3 is usually divided into A and B. And so usually that goes from about 45 to 59 for A, and then it goes to about 30 to 44 for B, and then it goes 15 to 29 for stage 4, and then less than 15 for stage 5, as we also define as end-stage renal disease. So with that, we need to see a GFR that's being persistently below the threshold, and usually in order for us to really diagnose a patient with CKD, we'd like it to be less than 60 to really kind of define the CKD based on GFR. And so the GFR that you gave me was 20. That's definitely less than 60. kind of puts this patient in CKD stage 4.
Okay.
All right. Because in this patient, again, it's greater than 15. It's somewhere in that range of where we say 15 to 29 is where I would say is stage 4. So I would diagnose this patient with CKD stage 4, given the GFR and given that it's been persistently elevated for 6 months. So that's what I would go with for that stage.
She has a few pretty scary lab findings, especially that hemoglobin A1C, her lipid profile, the GFR.
Yeah.
There's so many. What do you think is the likely cause of this patient's CKD? Kind of thinking about all those findings.
Yeah. So oftentimes the two most common causes of CKD that account for about 75% of cases is, I would say, diabetes and hypertension. So diabetes is going to be by far the most common cause. And usually we see this in patients with a poor, control of their glucose. And we see this with an A1C that's usually persistently elevated despite therapy, which this patient's on metformin and on insulin. So despite that, hemoglobin A1C was 8.5%. That means that they're probably experiencing a lot of chronic hyperglycemia. And that's going to lead to, if over time, non-enzymatic glycation, thickening of the efferent arteriole, and that'll lead to a lot of glomerulosclerosis. The other thing is hypertension. This patient has been diagnosed with hypertension, chronic hypertension. Yeah. They're on lisinopril, nothing else. But I can tell that they're probably not well controlled because their blood pressure on the visit today was 160/95.
Yeah.
So I think that there's probably a poor control of their hypertension as well. Maybe they need to be on some other agents.
Seems like there's a lot of poor control for this patient.
Yeah. So I would say those are the two likely reasons as to why this patient is experiencing CKD. And that is likely uncontrolled diabetes and uncontrolled hypertension.
What complications is she experiencing or is she at risk for?
So that's a good question because that's what we want to be watching for, right? Oftentimes CKD, especially in like CKD3, early stages of CKD4, we don't see many symptoms or many manifestations. As we get to CKD4 and we start even getting ready to go into CKD5 or end-stage renal disease, that's when a lot of complications start to arise. So what I'm starting to notice and what I look for is metabolic acidosis. There wasn't really much given to me about the ABG, so I'm not going to assume that there is any concerning metabolic acidosis. I also look for hyperkalemia. The potassium is just like a little bit elevated, 5.9. And so that is something that I want to watch out for. Hyperkalemia is a pretty common complication. If it starts to get high, at least greater than 6, I would consider getting an EKG. Make sure that there's no EKG changes as well, because that could be something that can be kind of concerning. And I would get her on some potential therapy for that. The other thing I would look for is hypervolemia. So hypervolemia can be in the form because she's having difficulty being able to excrete free water in the urine. I would look for findings of edema. So particularly this patient has in their explanation, pitting edema. So they have a lot of swelling of their lower extremities. That's one finding. A second one is also, I see the difficulty breathing when lying flat.
Yeah.
That's a very common sign of like orthopnea or paroxysmal nocturnal dyspnea. We see that in patients who have CHF, no doubt about it. But it also can be seen in patients with overbody, like fluid overload, which you can be seen in a patient with a very, very poor renal function. So I would say hypervolemia is likely also an unfortunate thing for this patient. The other thing I would be watching out for in this patient is evidence of uremia, especially encephalopathy. I don't find any findings of like significant confusion that was listed here. No findings of asterixis, which is something to watch out for. Nothing on the cardiovascular exam that suggests like a friction rub, which is good, and no evidence of any pericardial chest pain. So I think unlikely pericarditis. And then also, if you told me that she was having a lot of like bleeding or kind of like petechiae or purpura on her skin, or she's had lots of evidence of like epistaxis or mucocutaneous bleeding or GI bleeding, I'd be worried about uremic kind of bleeding. That can be another potential thing to watch out for, but I don't see that. So far I see hyperkalemia, hypervolemia. And then again, her BUN is up, but she's not having any very specific symptoms. So I don't see any uremia. The other thing is hypertension. Hypertension for this patient is begging the question, is it driving her disease, but is also, is it a result of the poor control that's led to CKD? Because CKD can also perpetuate hypertension and make it very, very difficult to control. So secondary hypertension is also a pretty common thing, but she is on the correct medication to treat that, which is the lisinopril. So that's good at least. The next thing I'd be looking out for is anemia. So was I given a hemoglobin? Hemoglobin's 9.8. That is a little low. So I would be starting to worry about anemia of CKD, which we can see in patients with very poor chronic kidney disease. They lose the ability to secrete erythropoietin, which tells the bone marrow to make red blood cells. Also, with chronic inflammation of the kidney, it can kind of tell the liver to increase its production of hepcidin, which can shut down a lot of the iron release from macrophages and then iron absorption across the gut. So I'm a little worried about that as well as the anemia of CKD. And then lastly, I'm also a little bit worried about the hyperparathyroidism. So the phosphate's elevated, which is very common. So she has hyperphosphatemia. Calcium's normal, but the PTH is elevated. This is identifiable as a secondary hyperparathyroidism. I would be starting to be concerned, is the patient developing any symptoms of renal osteodystrophy? So any kind of bone pain, increased risk of fractures, which I don't really see much in their medical history of lots of osteoporosis or pathological fractures or anything like that. And they didn't really get an x-ray, so I don't know if there's any osteotic cystic fibrosa. And the skin shows no calciphylaxis. So that is another thing. And then the last thing is hyperlipidemia. This can be a very common complication of CKD. And it's usually because patients also have diabetes, and diabetes predisposes you to a lot of risks, such as atherosclerosis. And so sometimes I see this elevated LDL and triglycerides. That could be the result of the liver increasing its production of lipoproteins in the scenario of a lot of albumin being lost in the urine. And that's the last thing I see there, which is the urine albumin creatinine ratio is 320.
Yeah.
That's macroalbuminuria. So heavy albumin loss in the urine that drives the liver synthesis of LDLs and VLDLs, which drives up their risk of atherosclerosis. So I would say, in a nutshell, the biggest complications this patient is experiencing is hyperkalemia, hypervolemia, anemia of CKD, secondary hyperparathyroidism. And I would even go as far as to say that they could have hyperlipidemia that's being a result of their CKD, or it's just a result of their diabetes. Either way, they have that as well.
All right, so we have a lot of different complications, a lot of different causes for those complications.
Yeah.
I want to try and go one by one and just try and jot down some thoughts as we go through each complication.
I think that's a good idea.
Each cause, and then say, hey, like, what do you do in this situation? How do you manage that?
I think that's a good thing. Yeah, let's do it.
So I know you mentioned before the metabolic acidosis. We didn't have an ABG. We couldn't really say that for sure, but let's just assume she did have metabolic acidosis. What would be your first step in managing that?
So I would first like to determine how bad the acidosis is. So if the pH is less than 7.2, that is kind of a nasty acidosis. It does predispose you to hyperkalemia, which is a big thing that I got to be careful for because this patient already has hyperkalemia.
Yep.
The second thing is it also increases the risk of, tachypnea, so they can breathe a little bit faster, unfortunately, and also it can cause hypotension too in severe cases. So if it was less than 7.2 and the bicarb was kind of low and, I didn't want them to get any worsening hyperkalemia, I'd probably start them on some sodium bicarb tablets. If it was really, really low and it was getting really bad and they were in the ICU, I'd probably start like an infusion, but outpatient or oral sodium bicarbonate tablets would be the way to go.
Now, you mentioned hyperkalemia a few times now. So let's just say she gets above that level of she's greater than 6. How would you manage a hyperkalemia in that situation?
So even in this patient with a 5.9, I'd be kind of like, I get started something.
It's still up there.
Yeah. If it was greater than 6 and she had ECG changes, or even if it was greater than 6 and there was maybe no specific ECG changes, I may be a little bit more aggressive in trying to get the potassium low quicker. Mm-hmm. But I'm going to push more for that when there's ECG changes. So if there was ECG changes associated with this, calcium, insulin, albuterol, those are going to be the bit. But my main goal is to get rid of the potassium and to prevent hyperkalemia. So I'm going to institute a low potassium diet. So I'm going to make sure that the patient is aware of what foods to try to avoid or limit to reduce the potassium intake into the body. And the second thing is this patient has hypervolemia and has hyperkalemia. That's the perfect scenario to give them like a loop diuretic. And so I put them on like oral, like Lasix of some sorts, or furosemide, bumetanide, torsemide. And that would be great at being able to excrete electrolyte-free water. On top of that, get rid of potassium. So That's something I would do. You can use potassium binding resins. Those are alternatives as well. I would say that that's more in a patient who really can't make urine. So they're anuric. And so a loop diuretic wouldn't work. In that scenario, I could give them a potassium binding resin as well. But I'd say for this thing, initiate a low potassium diet, get them on a loop diuretic. And then if I really, really needed to, I can consider like a potassium binding resin, but I'm going to try and get that potassium down. And then also be careful. This patient's on an ACE inhibitor. ACE inhibitors can perpetuate hyperkalemia a little bit. So just be careful. I wouldn't discontinue it because it has nephroprotective effects, but I would try to see, hey, let me treat this. And if it's not getting any better with a low potassium diet, the loop diuretic, I may decrease the dose of the ACE inhibitor potentially.
All right. Well, you already answered my next question. We talked about the hypervolemia. You're almost kind of treating that in conjunction with the hyperkalemia.
Exactly. And then the other thing is just kind of restrict sodium if you can. Keep it to less than 2 grams a day, just so that you don't get kind of like the sodium in the blood that it kind of retains more water. But otherwise, yeah, loop diuretics are the best thing for that as well.
How about the prevention of bleeding in uremia or uremic bleeding?
So if I have a patient who has uremia, so they have a super elevated BUN, and I have concerns like they have some epistaxis, maybe they have some mucocutaneous bleeding or something like that, I could consider desmopressin, but I think oftentimes the most likely utilization of desmopressin is if they have severe uremia and we're about to do a procedure.
Okay.
So if we're about to do like a central line, or they're about to get like some kind of like procedure that they're going to be surgical involvement in, and they're at high risk for bleeding, for example, like they're going to be doing some kind of surgery on the brain, like an external ventricular drain, whatever it may be, I don't want that person to not be able to plug up those holes in the vessels.
Yeah.
And so usually to prevent the bleeding during procedures, we'll give them a couple doses of desmopressin, because that'll tell the platelets to start producing von Willebrand factor, factor 7, and that'll help to kind of really initiate that clot formation.
All right. And the next one is a pretty big one is hypertension. How would you manage hypertension and even proteinuria in CKD?
Yeah, so that's always a tough thing, because you got a patient who has hyperkalemia, and the best drugs to treat hypertension in CKD and reduce proteinuria is ACE inhibitors and ARBs. So you have to find that fine line, because it's nephroprotective. Because if you reduce proteinuria, you reduce the risk of progression of CKD, and you reduce the risk of cardiovascular disease-related deaths. And so that's why ACE inhibitors or ARBs are really, really important. You want to try to keep them on. So for hypertension, the main mechanism behind it is that the kidneys sense that the GFR is low, and it pumps up renin production, leads to higher angiotensin II levels. And so that kind of vasoconstricts your vessels, causes you to trigger your ADH and aldosterone mechanisms. You reabsorb water and sodium, blood volume goes up, blood pressure goes up. So what I want to do is I want to shut down the angiotensin II at its effect. So I don't cause it to vasoconstrict. I don't cause the ADH and aldosterone to be high. So that's where I give like an ACE inhibitor and ARB. That's best for that, with a goal of trying to get the systolic blood pressure less than 130 and the diastolic less than 80. That's a nice goal. The other thing is the proteinuria. What's really cool is that ACE inhibitors and ARBs, they block angiotensin II, and angiotensin II vasoconstricts the efferent arteriole, which causes the pressure in the glomerulus to go up, and so you filter more albumin into the urine. If I give them an ACE inhibitor and ARB, they block angiotensin II, the efferent arteriole vasodilates, and blood can get out of the glomerulus better. Cool. So the pressure drops and you don't dump as much albumin into the urine. So that reduces the risk of a lot of progression and cardiovascular death. So that's what I was ARBs. They cover hypertension and proteinuria. You just got to be careful. You got to watch the potassium and watch their creatinine, because ACE inhibitors and ARBs do have the capability. You know, CKD, they're high risk. So just got to be
You monitoring that?
It depends. So if a patient who has CKD in pretty advanced stages, I would be very, very careful. I would probably be consider like monitoring that. Like if I'm being super aggressive, I might even go like every like month, 1 to 3 months, and I'd be very, very closely monitoring that.
Okay.
And I would be very, very careful, just because with these ACE inhibitors and ARBs, if a patient ends up having chronic kidney disease and they're at the later stages, they're pretty high risk. I think it's of utmost importance to be able to closely monitor that potassium.
Yeah, no,
level.
definitely. That would be pretty concerning level.
Yeah.
There. So how about management of hyperparathyroidism?
Yeah, that's a good one, because this one's tough. I think it depends on what the calcium and the phosphate levels look like. So for example, if I said that the calcium was on the lower side, so that like this patient, what was their calcium? It was a 8.2. So that's about normal. So that's not too bad, right?
Yeah.
So this is definitely secondary. I wouldn't be too aggressive with trying to go after the calcium. I'd go after the phosphate. That phosphate's pretty high.
Yeah.
And the PTH is high. So what I would do is I would say, okay, I got to try to get to the point where I can get the PTH to not be secreted so much on a low phosphorus diet. So I'd instruct them of what kind of foods to avoid and what to restrict. And then I would monitor that phosphate and see where it goes. If the phosphate is not coming down, that's when I say, okay, whenever you eat, I'm going to give you something that when that drug is actually taken with the food, it's going to bind up the phosphate in the food that you're eating so that you don't absorb it and you poop it out. And so if they're not adhering and they're not responding well to the low phosphate diet, I'll put them on a phosphate binder, usually like sevelamer, calcium carbonate, calcium acetate, one of those. Okay. And then I would look to see where the phosphate's going. And then I would even keep an eye on the PTH. So if the PTH is still high, then I may need to kind of figure out what I'm going to do. I might need to attack the vitamin D. Look, do I need to give them a little bit of vitamin D as well? So that's what I would do is I wouldn't give anything for the calcium. I'd focus on getting the phosphate down, low phosphate diet. Phosphate binders, if they don't respond, keep an eye on the PTH. If it's still high and it's not coming down, maybe consider giving them some vitamin D. That's what I would do for that one. But if the calcium and the phosphate and the PTH are all high, I'm kind of going towards the tertiary side.
Yeah.
And this is where I got to start asking myself the question, okay, should I give them something that can potentially shut down PTH production? because I can continue everything I'm doing already. Keep going to low phosphate diet, the phosphate binders, maybe some vitamin D. But then I got to start asking myself the question, they're not responding. Okay, I probably should put them on something called cinecalcet, which is a calcium mimetic. It will shut down PTH production by the parathyroids, and that'll prevent them from developing further hypercalcemia. The other question is if they're a candidate, I could refer them to surgery and to get a parathyroidectomy to reduce that risk as well. So those are kind of the ways that I would look at it. Start with the low phosphate diet, add on the phosphate binders, keep an eye on the PTH. If it stays high, consider vitamin D. And if it continues to get high, maybe consider the cinecalcet, especially consider it as if the calcium goes up along with the phosphate and the PTH. And then potentially reach out to surgery and talk about, could this patient be a candidate for a parathyroidectomy?
Okay. Hemoglobin was low. We talked about, or you were concerned with anemia of CKD. How would you manage anemia of CKD?
So the first thing I would do is, I told you that EPO is one of the big reasons, right? That the kidneys are struggling to make that. Problem is that oftentimes we should not start EPO until their iron levels are appropriate. And so we don't necessarily check their iron levels. We actually check other parameters to look to see that their iron's actually good. We didn't get that, but I would order that. I would order what's called a transferrin saturation, and I would also order a ferritin level. And I would look at those and I would say, okay, where's my ferritin? I at least, ideally, we want to get it pretty high. Like I'd like to get it up to like 500, but ideally I want it greater than 100. And my TSAT, my transferrin saturation, which is how much iron is bound to the actual transferrin, I want that higher too. I want that greater than 20%. So I want the things that are going to be binding to iron to be higher because it tells me that my iron levels in the body are a little bit higher. So I would aim to get those two normal. Once I've normalized them with an iron transfusion or iron supplementation, then I would give them something like erythropoietin. And the only way that we do that is when the hemoglobin is less than 10. So we're going to hemoglobin less than 10, iron stores are repleted. Okay, put them on erythropoietin. And that'll stimulate the bone marrow to pump out more red blood cells. The whole purpose of this is just to reduce the need for frequent transfusions. Okay. And so that's the whole idea behind this, and try to reduce symptoms as well.
Okay. Well, we treat all the complications. We treat everything that we need to. We get this patient discharged and she does okay. However, 6 months go by.
Yeah.
6 months go by and we get the same patient admitted again.
Okay.
Plot's going to thicken a little bit here.
All
okay?
right, hit me. Let's go.
All right. So same exact female, same patient. 65, presents to the nephrology clinic now with worsening fatigue, swelling in her legs, and increasing shortness of breath. The patient has been managed for chronic kidney disease secondary to diabetic nephropathy. Despite optimized medical therapy, including tight glycemic control, blood pressure management, and treatment of complications such as anemia and hyperphosphatemia, her renal function has continued to decline, unfortunately. Over the past month, she reports feeling increasingly tired with severe fatigue impacting her daily activities. She notes worsening swelling in her legs and now experiences shortness of breath even at rest. She also mentions a significant decrease in urine output over the past 2 weeks. Her past medical history is only updated for what we just diagnosed prior, which was the stage 4 CKD. Medications, she had a couple additional ones now. So she's still on the metformin, getting insulin, lisinopril, amlodipine, atorvastatin, but she's now getting an erythropoiesis stimulating agent, and she's on phosphate binders, as we just talked about. For her exam, we do her exam, we get vitals. BP is 155/92. Heart rate is 90. Respirations are 20. Temp is 97.9, and O2 sat 93% on room air. General, obese female, appears fatigued and dyspneic. Cardiovascular, regular rate and rhythm, S4 gallop, no murmurs, but now we note a 3+ pitting edema in both lower extremities. Before we had a 2+. Respiratory, we notice bibasilar crackles, mild tachypnea. Abdominal is soft, non-distended. Neurologic, alert and oriented, no focal deficits. And then skin is the same. It's dry. It's that excoriated skin with scratch marks.
Do you know why that is?
No rashes.
You know why that is? It's really interesting.
I would love to know why.
Yeah, for some reason, CKD, like the uremia, it can cause like pruritus. And sometimes, I'm not going to lie, that was one of the things that I always found was like one of the most interesting symptoms that patients present with is a lot of the pruritus.
So it's just the itchy skin, and that's just a byproduct of the uremia?
Yeah. And so she's probably just scratching away because she's so itchy.
Right.
And it's usually a complication of worsening uremia.
Wow. Cool. Yeah. That's a cool thought.
Yeah, it's just a little factoid, a little fun fact. Yeah.
All right, so we do a full lab again for her. We get all these lab findings, and some things are going to change, as you'll know. Creatinine we get back is 6. Prior, when we saw her last, it was 3.5. BUN is now 105. Hemoglobin 8.5. Potassium is 6.3. Sodium 132. Phosphate is 7. Calcium is 11.8. Parathyroid hormone is significantly elevated. Albumin 2.8. GFR 5. Oh my gosh. Her kidneys are filtering worse than my mom on social media. This is horrible, right? This is really bad. This is end stage renal disease.
Yeah, at this point she's
Has to be.
Yeah,
with
she's
the
now,
GFR less than 15.
Yep. Yeah, she's probably progressed. There's something that's probably happened over the time. Sometimes this can progress like this in 6 months. But yeah, this is unfortunate. It seems like she's kind of gone downhill, and her GFR has dropped pretty decent within 6 months.
We get her hemoglobin A1C back. It's 7.5%. It's better than 8.1.
At what cost?
That was better. Right?
Yeah, there's some positive there, I guess. Yeah.
Find the positives here.
Yeah.
Imaging findings, we do the same thing as before. A renal ultrasound, we get back, it's bilaterally small, same exact findings from before. Chest x-ray we do as well, and we do note now in her chest x-ray is moderate pulmonary edema. All right, Zach, our CKD patient is not doing too good.
No.
She is plummeting faster than my willpower at Chick-fil-A. Because I can't help myself when I go to Chick-fil-A.
Oh, same. 30 nuggets, bring them to me, baby.
God. Easy. No problem. What do we do?
I'd start figuring out last rites. No, I'm just kidding. No, in all seriousness, this is a patient that could be fixed. It looks really bad. And it is bad. It is bad. But I think that there's hope. It's just a matter of what are we going to do after we start doing this initiation of what I think is dialysis at this point.
That's what I was going to say. I mean, at this point, her GFR is so low. We're this is end stage renal disease. So if we're going to go ahead and start dialysis, let's just start with this. How about this? What are the two types of dialysis and how do they work? If we can start there.
So the reason why, first I would say the reason why we're going to initiate dialysis for this patient is just, like as you said, Rob, she's gotten so much worse. Like uremia is definitely present now. The BUN is greater than 105. It's greater than 100. Probably starting to experience some confusion. But I think the biggest thing is that there's persistent hypervolemia.
Yeah.
There's persistent hyperkalemia. That's a really concerning for me. And so those kinds of things are kind of adding to the picture. And plus they're at end stage renal disease. So GFR less than 15 with features of uremia, that's enough for me to start saying, hey, we got to initiate dialysis. So that'd be the big reason why for me. When we do dialysis, there's two types. The more commonly one I'd say within the United States is going to be particularly hemodialysis. That's like 85% of the patients are in hemodialysis. But there is peritoneal dialysis, and I'd say a lot of other people outside of the U.S. are utilizing this, and it's a really effective one too. But with hemodialysis, the concept behind this one is that you have to access the patient's circulation, their actual vascular system, and you're going to pull blood that's obviously in this patient rich in solutes that are waste products and rich in a lot of water that's abundant in this particular scenario, and potassium, and you're going to kind of run that into a machine, and this machine is a dialyzer, and in the dialyzer it's going to have like a particular membrane that's using a dialysate that's actually running in it, and it's giving a bath to that dialyzer, and the whole purpose is to flush out these waste products into the dialyzer, and then also kind of allow for the dialysate to run some particular molecules into the bloodstream. So if they're having acidosis, maybe give a little bit of bicarb. And so those are particular things that we would do. After it runs through the dialyzer, it comes back and then accesses their vascular system and replaces the kind of the blood that we took out of them. It's just now it's cleaned, removed of any waste product, and maybe even reduce some of the excess volume from them.
So we're just literally filtering it.
Yeah. The same kind of concept exists with peritoneal dialysis, but your access is not a vascular access. In this case, you have like a catheter that runs into the belly, into the peritoneum, actually. And what you do is the patient has dialysate. They infuse that dialysate in through the catheter into their peritoneum, and it sits there for multiple hours. And then their peritoneum acts like the dialyzer. So it acts like the machine. And so what happens is the dialysate that we put into their belly kind of pulls any excess waste products and fluid out into the peritoneum, and then a couple hours later, after you've actually allowed for that to work, you just drain the belly. And so it's kind of like a similar concept between the two. It's just in this particular patient, I would say that initiation of hemodialysis is a little bit easier and quicker and well known for urgent or emergent hemodialysis. You can do peritoneal dialysis urgently. I just say it's not as common in the States as it is in other different parts of the world. So I would say those are the two options. Most likely, I would say let's initiate hemodialysis.
Okay. What would be some complications if you got one dialysis versus the other?
It's a good question. I would say, because it depends. When we perform dialysis on patients, especially hemodialysis, we need to get access points. So you have to obtain access emergently in this particular patient. I'd say urgently / emergently. And so oftentimes we'll put in what's called a central venous catheter. We prefer for them to be tunneled as compared to non-tunneled. If it was like emergent, I would probably rush to put in a non-tunneled line. But in this patient, we have some time, so I put in a tunneled line.
Okay.
Only problem with tunnel lines is that you're putting a catheter, something that doesn't really belong into the body. It can increase the risk of infection. So having what's called a central line associated bloodstream infection is kind of a really bad thing. Increases the risk for bacteremia, sepsis, endocarditis. So that's one really big thing that I watch out for. If I needed to dialyze this patient afterwards, so let's say that I obtained the actual access, like the tunneled catheter, then I would reach out to a surgical team to say, hey, we need to get this patient a fistula or a graft. So that we can continue to access their circulatory system, because you can't just go in and like stick an IV into a patient and be like, all right, cool, let's clean the blood. No, you got to have a large access point where you can pull a decent flow of blood out. And so oftentimes the surgeons will kind of create like a little anastomosis between like an artery and a vein. And so you can allow for that to be the access point, which will take the blood, run it through the dialyzer. So that's one. I'd say the fistula is the one that takes the longest time to mature, sometimes up to like a month. Wow. So that's why you'd put the tunneled catheter in. After you put the tunnel catheter in, get the fistula, get them ready to reach out to surgery, get the fistula to form, give it time to mature. And then from that point, tunnel catheter comes out and you utilize the fistula.
Okay.
An alternative is a graft. Grafts are a little bit quicker, but they have poor patency. And so they can clot and get stenotic and stuff like that. So I'd say those are the big things. But the other thing is like when you dialyze a patient, you're pulling off volume, man. And so when you pull off volume off of a patient, you can actually pretty like significantly drop their blood pressure. And so hypotension is a pretty common complication with hemodialysis more specifically, because they can get pretty hypotensive, and that happens in like an ICU. A lot of the times we'll switch them over to what's called CVVH. It's like a continuous venous hemofiltration. It's like a continuous renal replacement therapy. So we'll just pull small volumes off constantly throughout the 24-hour period, or at least over a specific period of time. And so that's one thing that we would do in that scenario. I've seen it once, and I've seen cerebral edema. So sometimes in patients in like a neurological ICU, you be very, very careful because they already have maybe increased intracranial pressure or cerebral edema. And then if you pull off too much of the waste, urea is a osmolar agent. And so when you pull urea out and you get rid of it, you decrease the urea in the bloodstream. And what happens is you lose the ability to kind of keep water inside of the bloodstream, and water leaks right into the brain tissue, swells, and you can get headaches, nausea, vomiting, and increased intracranial pressure. So that's the big for that one. If we did do peritoneal dialysis, I would let the patient know you're putting a peritoneal catheter in. That catheter is in the skin. Bacteria can seed through that, and you can get an infection of the peritoneum, like a peritonitis. And so you have to watch out for like abdominal pain and tenderness of the abdomen, rigidity, fever, leukocytosis. But you probably have to pull some fluid off and test it and see if you have a lot of PMNs in there too. But that's, I'd say, the biggest complications really with the dialysis of the patient.
It's great that we could get this patient on dialysis. That's wonderful. It'll help, improve her quality of life, get her a little bit more, back to her baseline. But can't we consider her for a transplant?
That's always that's the problem with dialysis. When you put a patient on dialysis, you're kind of like, peritoneal dialysis is a little bit more like you can actually kind of live somewhat of a normal life.
Okay.
So that's why peritoneal dialysis is actually preferred in some types of areas of the world, because you put the catheter in, and then at night you put the diastolate in, and you let it run overnight, and then in the morning you dump it, and then you're done. You can probably go on throughout the rest of your day like nothing else is different. There's been studies that showed that patients who were on dialysis had a shorter lifespan as compared to patients who had a transplant. And so transplants will definitely improve the patient's quality of life. That'll improve their renal function, and it'll actually help to give them a longer life.
Yeah.
And so I would definitely push for a transplant. There's always different types of contraindications to getting a transplant. This patient, sometimes we look at it as if they have malignancy. There's no malignancy, no active infections like HIV or tuberculosis, no drug abuse, And if they had like a prior transplant, that would also be potentially a little bit more high risk. And so with that being said, and then age, I like anything less than 70 and greater than 1 year old. So in this particular scenario, I'd say that this patient is a candidate, and I would reach out to the transplant team and I would start seeing if I could find a transplant, whether it be a living donor or a deceased donor.
Sure.
And see if I could get this patient to get a transplant. I just might have to keep them on dialysis until I get that organ.
Right.
And then bridge them to a transplant.
It would make perfect sense.
Yeah.
But all right, well, that concludes the case that we have here on CKD. Prior to really wrapping this all up, I would love to get the Zach Murphy special. Okay, let's get a nice wrap up of CKD as a whole, and just make sure we walk away with the biggest high yield points.
Yeah, so I would say that CKD again can be defined as a progressive loss of renal function, defined as a gradual reduction in the GFR. Usually we say less than 60 is where we would define that. So CKD3 is usually less than 60. CKD4 is we would say it would be particularly less than 30. And then we would say that CKD5 would be less than 15, considering those ranges as we talked about before. If a patient had normal GFR, I would also consider another way that we define CKD as albuminuria, because albuminuria is an early predictor of CKD. And so in that situation, if it is like around less than 30, that's mild. If it's 30 to 300 for the urine albumin creatinine ratio, that's microalbuminuria. And if it's greater than 300, it's macroalbuminuria. It's important to remember that you can have this with a normal GFR and still have CKD. From there, I'd say what's the most common causes? Diabetes, hypertension. You can have other ones, but this is the most likely one. When you think about complications, think about metabolic acidosis, hyperkalemia, hypervolemia, uremic encephalopathy, pericarditis, and bleeding. Think about anemia of CKD. You think about hyperparathyroidism, and even the increased risk of atherosclerosis. When we're talking about how do we treat these patients, you're treating really the complications, as well as trying to be able to eliminate further damage. So don't really push to get these patients iodinated contrast if they don't need it, because it puts them at risk of CIN. Don't give them gadolinium contrast because it puts them at risk of NSF. Renal dose their medications so they don't end up with super therapeutic doses. Treat the acidosis appropriately, bicarb. Treat the hyperkalemia with low potassium diet and loop diuretics, particularly. If they're hypervolemia, sodium restriction, loop diuretics. If they have uremic bleeding or you're getting ready to do a procedure, desmopressin. If they have anemia of CKD, get their iron normal first, get the ferritin up, the TSAT up, then start them on an erythropoiesis stimulating agent. And then for hyperparathyroidism, get that phosphate down. Low phosphate diet, phosphate binders. Consider vitamin D if the PTH is persistently high. And if it continues or they go to a tertiary, get them on a calcium mimetic, reach out to surgery for a parathyroidectomy. And then lastly, with a patient who is having persistent complications despite medical management and they're going into the end-stage renal disease, start reaching out to nephrology to initiate dialysis for this patient. Earlier, the better, so that you can obtain access. AV fistula is the best. If you need it urgently, central venous catheter, an alternative to a life that's a little bit more physiological, peritoneal dialysis. And then if a patient could, the quality of life, the renal function, and just overall longevity would be better with a renal transplant.
I have one more question for you.
Okay.
We just did a podcast episode on AKI. Now we're doing CKD. What happens, or how do you really manage a patient who has an AKI on CKD?
That's always a good question. So usually if it's an AKI on CKD, I'm thinking about what's driving the AKI. And so if a patient has an AKI and they have chronic kidney disease, I'm not so much worried about the chronic kidney disease. I'll try and make sure that as a byproduct, I'm focusing on their diabetes or hypertension. But really, the main focus is what's driving the acute kidney injury. Then I got to go back to, is it pre-renal, intrarenal, post-renal? Figure those things out, treat those things, and the renal function hopefully will go back to what their baseline is.
So most pressing concern, handle the acute injury that's happening.
Exactly.
And then you can manage chronically.
Yep. That's it.
Cool. All right. Well, that is the episode on CKD. Zach, give it the send off.
All right, Ninja Well, I love you guys. I thank you guys so much for tuning in. I hope it made sense and I hope that you guys enjoyed it. Love you. Thank you. And until next time.